In the area of the elderly patient, there is a recent focus, particularly by Antonio Palumbo, who frequently joins us at these sessions, about how we need to be cautious about frail patients and to be modifying related to comorbidity. And this is definitely a key point. And we need to have the initial assessment to see if an elderly patient could have a stem cell transplant possibility, and what does the patient prefer actually in terms of aggressiveness to the treatment. But we also have these patients, some of them are very active, some of them are in a wheelchair. We need to pay attention to that. There is an idea that we should have an induction that should be more gentle, but then we also have information that triple therapy might give better results in some fashion. And so my question in this area is, how are you guys balancing the idea of adjustment for comorbidities and frailty, but also the notion that maybe more aggressive therapy with triple therapy might give a significant remission and survival advantage? And so how do you approach that when you're selecting therapy for your typical elderly patient?
I think that we have to start to use frailty scores. And Palumbo, on behalf of International Myeloma Working Group, published a couple of years ago the geriatric scale, including the charts on comorbidities and the activity daily living and the instrumental activity daily livings. I think that it's very important because Antonio Palumbo showed us elderly patients are different and are a heterogeneous patient population. And the frailty score is able to distinguish two different patient populations with a very big difference in overall survival. And the power to distinguish between frail and no frail has much more power than the chronological age and even the cytogenetic abnormalities.
Yes.
And I think that this is a key point. And now we are treating on the same way to all elderly myeloma patients, older than 65. And if you look at the different trials, my feeling is that the overall survival is not superior to 5 years. Why? Because probably in these trials, fit patients are included, but also frail patients are included.
Yes.
And frail patients early discontinue the trial and early die. So my position is that we have to differentiate between, I don't know if fit and frail, or probably frail and no frail, fit and frail.
Yes.
Yeah?
Right.
And to offer, of course, a much more intensive approach of therapy to fit patients, and probably we can achieve duration of response, progression-free survival similar to that we are obtaining in young patients. And for frail patients, we have to do a much more gentle approach, probably with just a 2-drug-based combination, modifying the dose. And for me, the objective in frail patients is to maintain the treatment, so to minimize the toxicity, to improve the supportive care. If the patient is on treatment, he can obtain a benefit. But if toxicity emerges, patient has to discontinue the therapy and probably...
Key point. Yes.
And this is my position.
So, but if possible, if the patient is able to tolerate, I know that a regimen which you have been using is the combination of the RD and the VMP, with which you've had really excellent results. So you would try to use that if the patient condition would allow?
Yeah, this combination, including VMP followed by RD, is extremely effective in fit patients. Patients between 65, 75, even up to 80, but fit patients. I would not offer this combination to frail patients because they early discontinue the treatment.
Okay. All right. So on the U.S. perspective, who would like to go first? I know that you really, Paul, have used a lot of VRD, but for the elderly light. So you want to comment on the use of that?
Well, yeah. So we have our sort of RVD Classic, which is built on the 14-day treatment and then the 1 week off. And then the RVD Light regimen has been built on a monthly to 35-day schedule with weekly bortezomib given subcutaneously, and the lenalidomide dose brought down to 15 milligrams. And the RVD Light regimen regimen has been led by my colleague and partner, Dr. Jacob Laubach, and also Betsy O'Connell, who's been also part of our, O'Donnell, I beg your pardon, part of our team on this. And Betsy and Jacob have shown that the RVD Lite platform is very well tolerated in older patients over the age of 75. Our oldest on the study is actually 90, and the response rates have been approaching 90%. So we've been able to maintain the efficacy of the regimen by balancing the toxicities, to Mary V's point. So we've been very pleased with the performance of the regimen. I do think, for example, newer agents like Activism have real promise in the older population, and will help tremendously address this issue of frailty. I have to say, in the US, I think we're blessed by an increasingly fit older population. And I think your point is well taken, Mary V, that we have to be able to distinguish those folks from truly frail, and recognize that also the treatment paradigm essentially doesn't change. You just adjust to what you do, with your point about supportive care. So we've been very pleased with the regimen.
And I agree very much with Paul. I think I like to try and teach our fellows and residents, we don't treat myeloma, we treat people.
Yeah.
So you have to look at the person, and you have to put it in its context. And and I think that the geriatric index and so on that Antonio brought to us was a tremendous rubric to help us at least start looking at these things. But the reality is, at the end of the day, individual patient, you can adjust it either way. And what we've heard already is you can adjust which drugs you use, how many drugs you use, and the dose of the drugs you use. So if we get into this cookie cutter approach where everyone has to get RVD this way or VMP this way, we're into trouble. And so we needed experience to prove that, because in a lot of the early trials we hadn't lower doses of lenalidomide up front or lower doses of bortezomib up front. And I completely agree with Paul, actually, that ixazomib is likely going to be particularly helpful, because more often than not, this population prefer an oral regimen if it's doable. So I think those kinds of adjustments, that if we can bring that, as we mentioned in our previous discussion, proteasome inhibitor, immune modulatory drug combination, if we can still use those two together in older patients, be it in less frequent or lower dose, then hopefully we can still achieve. And I really love the way Marie-V said, patients not going to do well if they're not on drug. Right. So if you end up experiencing so much toxicity, you have to take them off. So the goal is control disease. And again, it may not be down to MRD negativity right away. Let's get there gently and enjoy their quality of life. It's so important to ask them every time, are they, because for some patients, they really might want a minimalistic approach if it's going to be better for their quality.
But can I ask you, do you really use these scales, or do you use the eyeball test?
Well, I think it's maybe an informed eyeball test where the scales help you not just look at how well they're dressed and sitting up in the chair, but we start to ask them about what their activity are, what they do, because these scales are not built on magical assumptions. They're very much things that we should be doing every day.
And they've been validated,
Absolutely.
No, I agree. I think, Brian, though, your point's very well taken. I mean, in the clinic, the tool will help you. But at the end of the day, you're absolutely right. And the other thing is you can adapt as you go. So essentially, you see how the patient performs according to the schedule you use. I will emphasize one thing in the elderly that is important to bear in mind, and that's the relevance of vascular toxicities. That is very relevant, be it hypertension, be it cardiac, be it renal, be it otherwise. Those start to really matter. And I think in the elderly too, I'm very struck by the importance of adequate hydration and attention to all the supportive care issues that you touched on.
Right. But I mean, the final point related to what you said, Mary-V, is you need to adjust to allow the patient to stay on the therapy. And so many times you don't know that exactly when you start. And so you just need to be ready, maybe not at the beginning, but as you go through the first few months. Okay, so unfortunately, Dr. Paul Richardson has to leave us for a very, very important commitment here at EHA. So we really appreciate you taking the time out of your busy schedule to join us and give us your input so far. So,
Brian, it's an absolute pleasure. And again, my apologies for having to leave a little bit early, but I've got to go do a presentation at the meeting. But it's really been a pleasure as always, and such an informative discussion. Thank you, everyone.
All right. Thank you, Paul.